So think about the hidden architecture inside you. You know, the tissues holding everything together, bones, blood vessels, all of it. Well, sometimes there's like an error in the genetic blueprint for that framework.
Right.
And that can have these really wide-ranging effects. Today, we're going to unpack one of those conditions, Marfan syndrome.
Yeah, and it's actually more common than a lot of people might think.
Okay.
Understanding it gives you this fascinating window into how genes shape us, literally.
Exactly. And if you're listening in maybe to get your head around this for revision, you're definitely in the right spot.
Absolutely. We've basically taken a bunch of comprehensive notes on Marfans and boiled them down.
Just the key stuff you need.
Yeah, the high-yield information. We want to make it clear, memorable, really useful for you. Think of this as your shortcut to getting the essentials down.
Okay, let's dive straight in then. Marfan syndrome. What is it, fundamentally?
Well, at its core, it's a genetic disorder, and it affects the body's connective tissue.
Connective tissue, that's basically everywhere, right? Support, elasticity.
Exactly. It's the body's glue and scaffolding.
Yeah.
But with Marfans, the systems that really show the effects are primarily three. The skeletal system.
Bones and joints.
Right. Then the cardiovascular system, so heart and blood vessels.
Okay.
And the ocular system, the eyes.
So that's the main triad to keep in mind from the start. Skeleton, cardiovascular, eyes.
Perfect summary. And when we say genetic, the root cause, the main thing, is a mutation in a specific gene called FBN1.
FBN1. Okay.
Yeah. It sits on chromosome 15. And this gene, it holds the instructions for making a protein, fibrillin-1.
Fibrillin-1, and that's important for...
It's absolutely critical for connective tissue. It gives it strength, flexibility. Think of it like the reinforcing fibers in really strong, stretchy fabric.
Got it. So a problem with the FBN1 gene means faulty fibrillin-1. How does that actually get passed on? What's the inheritance like?
So Marfan's follows what we call an autosomal dominant pattern.
Autosomal dominant.
Yeah. So think about it. We get 2 copies of most genes, right? One from each parent. In a dominant condition like this, just one copy of the altered, mutated gene is enough to cause the condition.
Just one? Wow.
Yeah. So if one parent has Marfan syndrome, there's a 50% chance, a 1 in 2 chance, that their child will inherit that single faulty copy and develop the syndrome too.
50%. That's quite high. It's like a coin flip every pregnancy.
Exactly. But what about people who are the first in their family to have it? It doesn't always seem to be inherited.
Ah, good point. That does happen. That's where we see spontaneous mutations, or de novo mutations is the technical term.
Okay, de novo, new mutations.
Yeah. About a quarter, maybe 25% of Marfan cases pop up like this. The gene changes for the very first time in that person.
Any idea why these spontaneous mutations happen?
It's not always clear, but there is some evidence linking it possibly to the father's age at conception. Older fathers might have a slightly higher risk.
Interesting. So putting it together, the biggest single risk factor is definitely having a family history.
Absolutely. If a parent or another close relative has Marfan's, your risk goes up significantly.
And the notes we looked at really emphasize this. About 2/3 of cases are inherited this way.
Right. But we always have to remember the other third, the sporadic cases.
Yeah, that 1/3. It means Marfan's can appear seemingly out of the blue, even with no known family history.
Okay, so we've got the gene, FBN1, the faulty protein, fibrillin-1, and how it's inherited or arises new. How does this faulty protein actually cause the problems? What's going on at the tissue level, the pathophysiology?
Right. So the fundamental problem is the body making this abnormal fibrillin-1. Either it's defective or there just isn't enough of it produced because of that FBN1 gene mutation.
And fibrillin-1 is supposed to be providing that structural integrity.
Exactly. Resilience, stretchiness. So if it's faulty or missing, you get widespread weakness in the connective tissues.
Like the scaffolding is just weak,
Yeah.
doesn't hold up properly.
That's a great way to think about it.
Yeah.
And this weakness then shows up in different organ systems. Let's go back to our main 3. First, the skeleton.
Okay.
The abnormal fibrillin-1 allows for, excessive bone growth, particularly in the long bones. So you get increased height, disproportionately long limbs. Dolichostenomelia, that's the term you might hear.
Long limbs. Got it.
Joints also tend to be loose, hypermobile, and people often have that characteristic tall, thin build. The support structures are just too long and maybe too flexible.
Right, that classic picture, tall, long arms, long legs. That makes sense now. What about the cardiovascular system? You said that's a major area of concern.
Hugely important. Here, The weakened connective tissue in the walls of the aorta, that's the main artery leaving the heart.
Yeah.
That's particularly vulnerable. A really major complication is aortic root dilatation.
Dilatation meaning widening.
Exactly. The base of the aorta where it leaves the heart starts to stretch and widen. And this significantly ramps up the risk of aortic dissection.
Which is a tear.
Yeah, it's like the inner layers of the aorta's wall tear apart.
Mm.
And potentially aortic rupture, which is catastrophic. Both are life-threatening emergencies.
Okay, so aortic root dilatation leading to dissection or rupture risk. That's critical. Any other heart issues?
Yes, the heart valves can also be affected because they rely on connective tissue too.
Yeah.
Especially the mitral valve. It can become floppy, leading to mitral valve prolapse.
Prolapse, so it doesn't close properly.
Right. The valve leaflets bulge back, and that can sometimes cause blood to leak backward, affecting how efficiently the heart pumps.
Wow. So these cardiovascular problems, the aorta widening, the valve issues, they seem really central to the seriousness of Marfan's.
They absolutely are. And then how does the faulty fibrillin 1 impact the eyes?
So in the eyes, there are these tiny, delicate fibers, kind of like ligaments, that hold the lens in place.
Right.
If those fibers are weak because of the faulty fibrillin 1, the lens can actually shift out of its normal position, move around.
Yeah, it gets displaced. A term for that is ectopia lentis. Think of the lens being held by weak, overstretched strings.
Ectopia lentis, okay. And you mentioned lungs too.
Yeah, it's less common but still important. The connective tissue issues can make the lungs more prone to problems like spontaneous pneumothorax.
A collapsed lung.
Exactly, where air leaks into the space around the lung. And in very rare cases, even spontaneous lung rupture.
It's really striking how one faulty gene product, this fibrillin 1, can cause such a domino effect across the whole body. So if a doctor suspects Marfan's, what else might be on their mind? What other conditions look similar? The differential diagnosis.
That's a really crucial step because, yeah, Marfan syndrome does share features with other connective tissue disorders. So key things to rule out would include Ehlers-Danlos syndrome.
Which also has joint hypermobility.
Exactly. And often skin changes, too. Then there's Loeys-Dietz syndrome. That's another genetic condition, also with significant aortic involvement, sometimes even more aggressive than in Marfan's.
Okay.
And you also have to consider conditions called familial thoracic aortic aneurysms and dissections, where people are prone to aorta problems but don't have all the other signs of Marfan's.
So mainly other conditions affecting connective tissue and the aorta.
Primarily, yes.
Yeah.
But there are other things with maybe one or two overlapping features. For instance, arachnodactyly, those long, slender fingers.
Yeah.
That can sometimes be seen in other conditions, too. Same goes for things like aortic dissection or ectopia lentis or mitral valve prolapse. They aren't exclusive to Marfan's.
Right.
You might even briefly consider things like Fragile X syndrome or conditions causing tall stature like acromegaly or gigantism, just to be thorough in the initial thinking.
That seems like quite a list. Any tips for remembering those differentials, maybe for revision?
Yeah, you could group them, think. Other major inherited connective tissue disorders first, like Ehlers-Danlos, Loeys-Dietz. Then maybe conditions that mimic the skeletal signs, like the tall stature ones. And finally, just remember that some individual signs, like the lens dislocation or aortic tear, can happen in other contexts. It's about seeing the whole pattern.
That helps structure it. Okay, what about how common Marfan syndrome is? The epidemiology.
Globally, the estimate is around 1 in 5,000 people.
1 in 5,000. That's, yeah, more common than I'd have guessed.
It is, and importantly, it affects all genders, all ethnicities, pretty much equally. The notes we used mention that the specific prevalence in the UK isn't actually pinned down precisely.
And where does it sit in the league table of inherited connective tissue disorders?
It's actually the most common one.
The most common. Wow.
Yeah. And, understanding and managing it has made a huge difference. Historically, before we had good treatments, the average life expectancy was tragically low, maybe around 32 years old.
Only 32.
Yeah. But now, with proper care, many people can live well into a normal lifespan.
That's a massive improvement.
Huge. But it's still really important to remember that the cardiovascular complications, especially those aortic problems, are still the main cause of death. About 1 in 10 patients are affected by serious aortic events.
That historical context really drives home how vital diagnosis and management are. Okay, so let's talk specifics. What are the key signs and symptoms a clinician is looking for? The clinical features.
Well, the big thing is that multi-system involvement we keep mentioning. You're looking for features across the skeleton, eyes, and cardiovascular system.
Right.
So common skeletal things. That tall stature, long limbs, loose joints, hypermobility, often spinal curves like scoliosis or maybe chest wall, changes either sunken pectus excavatum or protruding pectus carinatum.
And the long fingers.
And definitely arachnodactyly. Those long, thin fingers are a classic sign.
And you mentioned there are specific ways to test for that arachnodactyly.
Yes, two quick bedside signs. There's Walker's sign. You ask the person to wrap their thumb and little finger around their opposite wrist. If the thumb and finger overlap significantly, that's positive.
Okay.
And Steinberg's thumb sign, you ask them to make a fist with their thumb tucked inside. If the tip of the thumb extends clearly past the edge of the hand on the pinky side, the ulnar border, that's positive.
Walker's and Steinberg signs. Good memory aids. What other clinical clues might point towards Marfan's and other systems?
Cardiovascularly, you're listening carefully for murmurs, maybe suggesting mitral valve prolapse, and assessing for any signs suggesting that aortic dilation. Ocularly, besides the lens dislocation, people might just be very short-sighted, high myopia, or have a higher risk of retinal detachment.
Okay. Anything else?
Yeah. Other things you might see include a high-arched palate, flat feet, pistol and so on. Some people might have a history of spontaneous collapsed lungs, the pneumothorax, as we mentioned, and dural ectasia.
What's that again?
It's a stretching or ballooning of the dura, the membrane covering the spinal cord, usually in the lower back. It can sometimes cause chronic back pain or headaches.
And you mentioned skin and facial features too.
Yeah, you can sometimes see stretch marks, striae, especially on the lower back, shoulders, hips, even without big weight changes. Neurologically, that dural ectasia can cause the back pain or postural headaches that get worse when standing up. And facially, sometimes a long, narrow face, maybe some specific eye or jaw characteristics.
It really sounds like a thorough head-to-toe examination looking for this whole constellation of signs is absolutely key.
It really is.
So once Marfan's is suspected based on these features, what investigations are used to confirm it?
Well, the whole process starts with that really detailed history, personal and family, and the physical exam we just talked through. Then you move to specific tests. Echocardiography is fundamental.
The heart ultrasound.
Exactly. To get a good look at the aortic root size and check the heart valves. And this isn't usually a one-off. It's typically repeated every year to track any changes in the aorta.
Annual monitoring. Got it. What about seeing the rest of the aorta?
For a more complete picture of the whole aorta, you'd use cardiovascular MRI, CMR, or sometimes a CT scan. If things look stable, maybe repeat every 5 years. But if there's already some widening, some aneurysmal change, then it's usually annual imaging as well.
Okay. Any other tests?
If someone's having symptoms like palpitations or dizziness, a Holter monitor that's like a wearable ECG recorder worn for 24 or 48 hours can check for any heart rhythm problems or arrhythmias.
Right.
And if someone has those persistent headaches or back pains suggestive of dural ectasia, an MRI of the spine might be done to confirm it.
Interesting. And you mentioned a hip finding earlier.
Yeah, sometimes a simple pelvic x-ray can show something called protrusio acetabuli. It's where the hip socket is too deep and the head of the femur pushes in. Apparently, it's seen in about half people with Marfan's.
And shouldn't we also mention the Ghent criteria? They're often used for diagnosis, right?
Absolutely. The revised Ghent nosology or criteria are really important. They provide a structured way to make the diagnosis. They combine major and minor clinical findings across the different systems, plus family history, the presence of ectopia lentis, aortic root size, and crucially, genetic testing for that FBN1 mutation.
So genetic testing is part of it.
It is. But it's important to know that finding an FBN1 mutation helps, but it isn't always diagnostic on its own. You still need the clinical picture. The Ghent criteria help weigh everything up systematically.
Okay, so it's a combination of clinical assessment, imaging, and sometimes genetic testing, often guided by the Ghent criteria. Once the diagnosis is made, how is Marfan's syndrome managed?
Management is definitely a team effort. You need input from cardiologists, orthopedic surgeons, ophthalmologists, geneticists, a whole multidisciplinary team.
Makes sense, given how many systems are involved.
Exactly. And the main goals are really twofold.
Yeah.
Prevent the serious complications, particularly the aortic ones, and help the person have the best possible quality of life.
Okay. How do you do that? What are the main strategies?
Well, there's non-drug management.
Yeah.
That includes psychological support, which is really important, and specific lifestyle advice. Generally avoiding really strenuous activities.
Right.
Things like contact sports, competitive sports, heavy weightlifting, even scuba diving, anything that puts sudden, intense strain on the aorta or joints.
Okay, that makes sense. And medications.
Meds are crucial. Beta blockers are very commonly used. They help lower the heart rate and blood pressure, reducing the physical stress on the aortic wall.
Right. Slowing things down a bit.
Exactly. And another important class of drugs are angiotensin receptor blockers, or ARBs, like losartan. There's good evidence they can help slow down, or sometimes even slightly reverse, the widening of the aortic root.
Beta blockers and ARBs. Are there others?
Those are the mainstays. Research is always looking into other potential drug treatments, but those are the key ones right now.
And what about surgery? You mentioned the aorta risk.
Surgery is a really critical part of preventing disaster. Prophylactic aortic root surgery, meaning surgery done before a tear happens, is often recommended once the aorta reaches a certain size threshold.
To fix it before it breaks.
Precisely. The preferred operation, if possible, is often a valve-sparing aortic root replacement. The David procedure is a common name for one type. This replaces the weakened aortic root tissue, but keeps the person's own aortic valve.
Oh, that sounds ideal, avoiding an artificial valve.
It is, if feasible. If not, the alternative is a composite graft replacement. That involves replacing the root and the valve with artificial components. The downside is that it usually requires lifelong blood-thinning medication and anticoagulation.
Okay. Any other surgical approaches?
There's also a newer technique called Pier's personalized external aortic root support. It involves creating a custom-made mesh sleeve that knits snugly around the person's own aorta, providing external support.
Interesting, like an external scaffold.
Kind of, yeah. And of course, surgery might be needed for other issues too. Urgent referral to ophthalmology if there are eye problems, maybe surgery for significant scoliosis, orthodontic work for jaw issues.
And pregnancy, that sounds like a high-risk situation.
Extremely high risk. Pregnancy significantly increases the strain on the cardiovascular system, and the risk of aortic dissection goes up quite a bit. It needs very careful planning and expert management by a specialized team throughout.
So a very proactive, personalized approach across all these areas. What's the overall outlook then? The prognosis and what complications can still occur?
Well, the prognosis, as we touched on, is so much better than it used to be. Really dramatically improved. With good diagnosis, regular monitoring, and the treatments we've discussed, many people can expect to live a relatively normal lifespan.
That's fantastic news.
It really is. Early use of beta blockers, the advancements in aortic surgery, they've made a massive difference.
But the risks aren't zero, right? What are the remaining concerns?
No, the risks aren't zero. The biggest ongoing concern remains that potential for life-threatening aortic dissection or rupture. Cardiovascular problems are still the main cause of mortality, unfortunately.
Right.
However, we know that having that prophylactic surgery, especially if done early, leads to really good long-term survival rates. One interesting thing, though, as people are living much longer now, which is great, we are starting to see more late complications, things like aneurysms or even dissections happening in other parts of the aorta further down from the original repair site.
Oh, right. So fixing one part doesn't mean the whole aorta is safe forever.
Exactly. Just highlights why lifelong, careful surveillance and follow-up are absolutely essential, even after successful surgery.
Yeah.
You have to keep monitoring the entire aorta.
Continuous vigilance is key. Okay, so to wrap up, what are the absolute must-remember points about Marfan syndrome for our listeners, especially if they're revising?
Okay, key takeaways. It's genetic, caused by a mutation in the FBN1 gene leading to faulty fibrillin 1.
Affecting connective tissue.
Right. Primarily impacts three systems: skeletal, cardiovascular, and ocular. Remember that triad.
Skeleton, cardiovascular, eyes.
The biggest danger is the aorta dilatation, dissection, rupture. So regular monitoring, especially echocardiograms, is critical.
Management involves lifestyle advice, medications like beta blockers and ARBs, and often timely aortic surgery.
Exactly. And the great news is, with this kind of proactive, multidisciplinary care, the prognosis is vastly improved, and people can lead long, fulfilling lives.
It's really quite something how that single gene flaw can cascade through so many systems. It makes you think about how interconnected everything is in our bodies, doesn't it?
Absolutely.
And you wonder what breakthroughs might come next from understanding these connections, maybe for other complex genetic conditions. It's definitely food for thought.
It is indeed.
Now, if you want to dig deeper or need more structured revision materials on Marfan syndrome or other topics for exams like the MSRA, definitely check out passmsra.com.
And there's also freemsra.com for, well, free resources too. Both are great platforms.
Absolutely. Well, thanks for joining us for this deep dive into Marfan syndrome. Keep up the great work with your learning.